This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Series webinar. My name is John Furman. Before we get started this evening and introduce our speaker, we'd like to give an overview of our free program to those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speaker for this evening, Dr. Patrick Agnew, and then we'll have a Q&A session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who's on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with the EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife, who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 75 groups to date. Each group is given their own free website with a link from the directory and map. We received feedback that the conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Upcoming events include the EDNF conference in Baltimore, held August 13th through 15th. Hope to see you there, and we will be speaking at the conference in an educational session this year about support groups. For those attending live, there will be an opportunity for Q&A after this presentation. Add your questions at any time during the presentation by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Patrick Agnew, and he's going to talk about foot and ankle issues associated with EDS. He has been board certified in foot and ankle surgery since 1990 and trained in microvascular surgery at the Uniformed Services University of Health Sciences. Dr. Agnew is on the Professional Advisory Network for the EDNF Foundation. He is the founder and director of the Eastern Virginia Medical School Podiatric Medicine and Surgery Residencies, and a member of the American Podiatric Medical Association, also the Virginia Association in Hampton Roads Podiatric Medical Society, and Association of Military Surgeons of the U.S. He's a past president of the American College of Foot and Ankle Pediatrics and the Hampton Roads Podiatric Medical Society, a fellow of the American College of Foot and Ankle Surgeons. And he is the pediatric section editor of the Journal of Foot and Ankle Surgery. Agnew is a retired captain in the U.S. Naval Reserve, and he was decorated for his service during Operation Desert Shield Desert Storm. So with that, we wanted to welcome you, Dr. Agnew, and especially thank you for your military service and your many contributions to the EDS community. And we're looking forward to your presentation tonight. Your slides are going to be loading on the screen momentarily, and I'm going to go ahead and turn over the microphone to you.
Thank you, Dee, very much. It was an honor and a pleasure to serve, and it's been very educational and enlightening to work with patients with Ehlers-Danlos syndrome. I'll tell you a quick story about how that happened. Back in, gosh, I can't remember what year, must have been around late 1980s, the second annual meeting of the Ehlers-Danlos National Foundation was held in Chesapeake, Virginia, a town right next to where I live in Virginia Beach, Virginia. And I saw a little 3x5 card on the doctor's bulletin board. We actually had bulletin boards back then with push-pins that said there was going to be this meeting, and I was new in practice. I didn't have any patience, so I went to the meeting and sat in the back of the room while Dr. Pat Alessino, a local hand surgeon who just recently retired, former naval officer, talked about his knowledge and experience with EDS. And he came up to me at the end of the meeting and he said, what you doing here, Pat? And I said, well, you know, I didn't have many patients yet. I figured all these people have sore feet. And he said, yeah, they do. He said, nobody seems to be really doing anything about it. How'd you like to help out? I said, sure. So we went to a hotel room next to the lecture hall and took biopsies of people's shoulders and little punch biopsies of the skin, sent them off to Seattle, and right away I started asking questions about, hey, nice person for letting us biopsy you, what's going on with your feet? And right away I found out that I was right, that everybody I spoke to had foot or ankle problems. And so I started going to the national meetings every year and collecting knowledge, collecting experience, finding out very quickly that there is no homogeneous rule that applies to everybody with EDS or any collagen disease, but there were some fairly unifying characteristics that I started to write in medical journals about. Learn from my patients constantly new things, but I've tried to think of ways in which a foot and ankle specialist might be able to help. And so that's why I'm here tonight. Another 25 years later, and I've put together just a handful of slides here. I think a total of about 30 that summarize some of these experiences and some ideas that I think might help. And then I'm really looking forward to attacking these questions and answers. I see there are already 21 up there. I had 14 a second ago, so I guess we'll see how many of the questions get answered in the talk. So some of our previous research, as I say, that first meeting I went to out of town the following year was in Seattle, Washington, where we circulated a survey to all, 12, 13 people that attended and asked questions about experience with foot and ankle problems. And it was about 100% penetrant. A year or two later, we were at Detroit Children's Hospital, where the local pediatric orthopedist arranged to have x-rays taken of the attendees, and we measured some angles and analyzed the x-rays as we would anybody's foot x-rays, and we found out that there were some unique characteristics. The feet of people with Ehlers-Danlos syndrome can start out with any the typical characteristics of the general population. They may be high arched, they may be lower arched, they may be neutral, and they could have all kinds of individual things going on. But What we also found out was when they bore weight, and these x-rays were taken in a weight-bearing attitude also, one thing stood out on most of the x-rays, and that was that the longitudinal arch of the foot, that thing that when you look down at your foot to see your arch, was very low. And it wasn't necessarily because the foot pronated or undersupinated or some of the terms you may hear in a running shoe store from a foot and ankle specialist. Just kind of drooped, just kind of sagged all the way along the whole length of the arch, indicating that each of the joints along the arch was stretching beyond its normal range, lowering the arch. And that was very interesting because a lot of interventions for lower arch feet are designed to control over pronation. It doesn't always work in people with collagen disease. We'll talk more about that in a little while. We then used a machine called FootMax that I was loaned by a company in Canada that was, you can see basically the same technology at the Walmart store now if you go in to buy some Dr. Scholl's arch supports, that thing you step on that makes a little graph of your foot is really basically what this technology was back in the early 90s. And we were very excited about this. We thought this would be like the EKG of the foot, that we could really understand foot function. Well, we still don't know what to do with this data, but we did have a number of people walk back and forth over these scans and collected the data, and we have it in a nice computer disk and don't know what to do with it. But the difference between this scanner and the scanner you see in the store when you're buying over-the-counter arch supports is that it is dynamic. So we can see from heel strike to full weight bearing to propulsion what happens to the pressure on the sole of the foot. So interesting information, not very practical at this time. And each of the meetings I've gone to since then, I've tried to collect little bits of information. I've had the opportunity to meet very many people with collagen disease and in the majority of cases Ehlers-Danlos syndrome at the national meetings, and just have built my personal experience in this. And as I say, I learn something new every time. So I'm not going to belabor, I'm not going to go through a long lecture about collagen disease. I think a lot of people who come to the national meetings, and probably a lot of people who are attending this conference tonight, already know a lot about collagen disease in general. But just to summarize, the prototype collagen disease is osteogenesis imperfecta, in which collagen type 1 is faulty. This affects not only ligaments and tendons, but also bones. And so children will sometimes be born with fractures and sustain many fractures in early childhood. Sometimes their parents get carted off to jail thinking they're being abused until somebody makes a proper diagnosis. So it could be a terrible thing, and like EDS, there's a broad spectrum from a kid who breaks one bone in childhood to a kid who's broken 10 in infancy. So the penetrance of the genetic flaw is variable. Marfan syndrome may be the best known of the collagen diseases. And there's theory that Abraham Lincoln might have had it, and every once in a while you hear about a basketball player will have an aortic aneurysm and have to stop playing or even die on the court. And this is sometimes Marfan syndrome, since they tend to be rather tall and have long fingers and long toes, and actually make pretty good basketball players up until something goes wrong. And then, of course, Ehlers-Danlos syndrome we're here to talk about this evening. There are some special considerations. This is my family, by the way. They're beautiful like their mom, and they do pretty well in school. So I'll take a little credit for that. The special considerations of treating people with collagen disease include knowledge and experience with soft tissue handling. In many cases, the vasculature of the foot and ankle might be extra fragile, so we have to be careful how we handle that, not pulling or pushing too hard. In some cases, the bones may be kind of fragile, usually not in people with Ehlers-Danlos syndrome, although disuse, atrophy, and osteopenia can occur because of inadequate stimulation of bone through exercise. And the weird thing that surprised me, I found out pretty early on, is you can still have a tight Achilles tendon, even though everything else might be flexible. The ankle might not be able to flex back toward the shin enough. So you can be kind of tiptoed or tight Achilles tendons with everything else in the whole body flexible. And there's some very important pathomechanical effects of that. So there's my daughter. Guys, forget it. Her husband's a sniper. Very good one. So give it up. No chance. So common foot problems. Hypermobility of the foot, where it flattens out a lot more than it should. And flat feet with or without overformations we talked about in those x-rays. That matters. So a lot of common foot problems seem to occur in people with collagen disease, like bunions and hammer toes, but sometimes we see uncommon manifestations. So here are photographs of a patient with bunions. I don't know if you can see my pointer on the screen. I think there's a way to do that. Stand by 1 second. There we go. So here you see what might be just a kind of bigger than average bunion. This patient actually has already had a bunion operation that didn't work very well. And there's a little scar there from the incision. But what's happened here is the joint fluid has leaked out of that bunion joint, and this creates a pseudo-tumor or soft tissue mass over top of the bunion itself, which is, like on this foot, a deformity of the joint. So kind of a crazy thing you don't usually see, but you do if you take care of people with collagen disease. So carrying on, here's my littlest boy, Matthew. He's 17 now. He's about to get slaughtered by this wave. We do get waves in Virginia Beach, believe it or not. We actually have the United States' longest surfing contest, the East Coast Surfing Championship, here every year. We're up to like 52 years now. But he did survive. He's a big boy now. So what do I do as a foot specialist, or what do I recommend to other foot specialists? I recommend that we try to align and maintain optimal anatomy. Left alone, this foot that tends to flatten out too much distorts. Bones look like rocks, but they act more like trees. If you have constant push or pull on a bone in an undesirable way, over time that bone will change shape, and the joint can become damaged that bone connects to. And so we try to keep things lined up properly right from the start, as soon as the diagnosis is made. Of course, some people with collagen disease have fragile skin, so sometimes things that would work in the average person, an arch support that might be kind of aggressive or firm, might hurt or damage the skin, so we have to be careful about that. We don't rely on your ligaments to do things. So a lot of bunion operations, ankle stabilization operations, flat foot procedures are designed using the patient's ligaments to try and reposition things and make them work better. Well, of course, you can't really count on ligaments with people with collagen disease. So we have to think of better ways to do that. And then, as is often the case, especially with my experience in pediatrics, patients kind of show up when they show up. You don't always get control over that. So we don't necessarily get a child early on when they're first diagnosed, and we can intervene gently. And sometimes later on, our choices are limited. It'd be ideal if every kid with collagen disease was diagnosed at a very young age and we could intervene right away and kind of prevent some problems in the future. But we have to select the proper treatment for the time in which this patient presents. And that is a limiting factor, but an important one to understand. So here's Matthew a little bit over, kicking some kid's butt in wrestling. My kids are good wrestlers. The older boy, Michael, was the city second in the city of Virginia Beach, which is a pretty big thing. We get some really good wrestlers from around here. There's a wrestling move called a Granby. It's named after a high school about 10 miles from me. Anyhow, and there's Matthew gonna pin this kid. So, foot orthoses, arch supports, are very commonly used. Unfortunately, there's precious little scientific data on their efficacy and appropriate use. And so we use them all the time in the hopes that they will help, and often they do, and sometimes they don't. But again, this is kind of more art than science. We really don't have the scientific data on it, so there's still a lot of controversy among doctors about whether they're helpful, whether they're indicated, and insurance companies unfortunately take advantage of that to often not pay for them. So that's a whole other issue we probably won't touch on very much tonight. Arthrodesis, or fusing joints together, is what it says in most of the textbooks when you talk about hypermobile foot and ankle, is fuse the joint. And it's true, if you fuse a joint, that joint doesn't hurt anymore and it doesn't move anymore. But the bad news is, in my experience, and my experience is very biased, because everybody I see has a foot problem. That's why they came to see me. So I can hope that a lot of people had arthrodesis type procedures and had good outcomes, but I get to see all the ones that have bad outcomes. And I see a lot of those. And my thought behind this is that if you're hypermobile everywhere and you fuse one joint, all the joints around it kind of fall apart. So rushing to fuse a joint can be a very bad idea. Also, as I was trained, you never do your last procedure first. So if you have to do some kind of intervention, an arthrodesis is usually considered kind of a salvage, last option treatment, but there are lots of other things you probably want to try first. Save that as your very last option. Arthroereisis is also controversial. Again, not enough data on it, but this is a process in which we limit the movement of a joint through implantation of a device, often in the joint just below the ankle called the subtalar joint. This has been very exciting and useful for a lot of people with hypermobility for whatever reason, and we've had very good results in a lot of patients with collagen disease, and specifically EDS. More on that later. Ligament replacement. This is a very exciting thing that we've been involved in for the last several years, in which rather than trying to reconstruct ligaments, as is often recommended in orthopedic textbooks, we actually try to replace those ligaments with more reliable things like Dacron polyester webbing or suture material, using bone anchors that we kind of hijacked from shoulder surgeons to try and hold things together better. There isn't a lot of data on this yet, but collecting data and presenting it at the last 4 or 5 national meetings I've been to, we've had opportunity to present some experience with it, and it's exciting. So, yeah, I see somebody commented mediocre results. Yeah, I agree. We don't want mediocre results. We want really good results. So arthrodesis way down the list. Carrying on. Subtalar arthroereisis. Pretty good results with this. And here's a little illustration of how it's done. One of the exciting things about this is there's a small incision. If you see the illustration on your left, this can be just a handful of millimeter size incision. Then on the right, you can see a little screw device, a cylinder, that's been put into the sinus tarsus, the little hole in your foot below the talus and above the heel bone, the calcaneus. And most people don't know you have sinuses in your feet, and the contents of this is a fat plug called Hoke's tonsil. So hardly anybody knows you have sinuses and tonsils in your feet, so you can astound your friends with that at the next party you go to. But by putting this little plug in there, it works almost like a doorstop to keep the foot from flattening out too much, particularly if it's a foot that tends toward overpronation. My daughter, again, guys, remember, don't even think about it. She's away at college here at George Mason University. She's a graduate now and a school teacher. So subtalar arthroereisis goes back actually very far. We'll talk more about that in a second and what the goals, disadvantages, and advantages of the procedure are. You'll notice in my daughter's room up in Fairfax, Virginia, she's got surfing posters. They call kids from Virginia Beach that go to George Mason University fish out of water But they talk about weird things like Volcom, which is not a guy on Star Trek, it's a surfing brand, carrying on. And there's Michael, my oldest boy, who was on the U.S. surf team and was at one point the number 4 amateur surfer in the country. And you can see why. He's a little hot shot. So history of this subtalar arthroresis. Way back in the 40s, pieces of bone were inserted into that sinus tarsus to block movement. Usually worked great at first, but anytime you take foreign bone or even the patient's own bone and put it in a particular place, the body will rearrange it and do what it thinks it's supposed to do with it so it doesn't last. In the 70s, they started using elastic or a silicone polymer to accomplish the same goal, and it worked remarkably well. Unfortunately, silicone got a really bad rap through a big lawsuit with Dow Corning and breast implants soon after this. And also, there were cases where little bits of silicone would move away from the implant and into local tissues, a thing called detritic synovitis, and sometimes would irritate people. That was actually quite rare. Currently, there are metal implants, absorbable implants, and hybrids of metal and stronger polymers like polypropylene that have been in a lot of patients for a lot of years, decades, with very good results. So a little more history, polymers, metals, absorbable materials. There's Michael at his current size and shape and still ripping up waves. There's Michael with world champion C.J. Hobgood back in 2001, receiving a trophy for East Coast Championship. So relief of pain is our goal, not making a higher arch. This is really important because I think sometimes people get their goals wrong and then they get their results bad. So you got to know what you're going in here for. You're here, when you're having this procedure, you're doing it to relieve pain. We want to improve joint alignment and function. That's how the pain usually gets better. We want to interrupt the progression of pathomechanics. Left alone, again, the foot gets worse and worse over time. So if we can realign it, make it work more like it was designed to work, maybe we can prevent some of those late-term problems like severe osteoarthritis, degenerative disease of the joints around the foot. Correction of deformity, not really the goal. Frankly, nobody cares if you have an arch or not. It's not sexy. Nobody cares. It's just we need the foot to function properly. So a common mistake is to use too big of an implant. More on that in a minute. Here are some implants. Top left is one of the older versions, which is implanted into bone and uses a polypropylene polymer. The one on the top right is the one I have the most experience with. One on the bottom right is one of the most sophisticated hybrid versions that's become very popular recently. And all these things are about a centimeter long and anywhere from 6 to 12 millimeters in diameter. So they're little things. Let's see. Another one implanted into bone here. We don't really use anymore. These are much more akin to what we use. This one's designed to avoid irritation of the bone on the edge of the joint. And this one's kind of clever. It's got a polypropylene shell and a metal implant inside. You can twist a screw on it and adjust the thickness of it. So that's kind of exciting. Carrying forward. So there's Michael in Kill Devil Hills, North Carolina, and he did survive that race and won that contest. That's the Fulton contest, actually. I am the editor to our journal in pediatrics, so I get to see a lot of journal articles sometimes early on before they're published. This one's been published since in 2007, but the purpose of the study was to find out if absorbable implants worked better than metal implants. Well, the study totally failed to do that, but it did have a very interesting bit of information came out of it. They did CT scans of the sinus tarsus as part of their study, and their data on the size of the sinus tarsus was that it's a lot smaller than you think it is. So sometimes in the effort to create a higher arch, surgeons will use too big of an implant and it'll hurt. And so I know some doctors who really don't agree with this surgery and will take them out all the time, particularly if people have any symptoms, or sometimes just because they want to take them out, I think. But I'm happy to say that out of the many hundreds that I've put in, I've only had to take out 2 or 3, and that's been usually because of trauma. Someone twisted their ankle, injured themselves, and got knocked out of position. So I think if you go in with the right goals, like we talked about earlier, you get good results and you don't have to take the implants back out. Some surgeons do recommend putting these in relatively young children and then taking them out routinely. Sorry about that. I don't know if you can hear my dogs barking, but we have this whole little wolf pack of teeny tiny little dogs. But some doctors routinely remove them in an effort to allow the foot to align itself. I'm not sure that's a realistic goal. I only take them out if they bother people, and as I said, it's done very rare. Another condition that unfortunately affects people with collagen disease more commonly than the rest of us is clubfoot and metatarsus adductus, which is part of a clubfoot deformity. And these are thought to be more packaging defects versus manufacturing defects. If the ligaments are, it's usually in an infant, the ligaments are hard and the bones are soft. Before a baby's born, the bones are made of cartilage and they're soft and they're malleable. The ligaments are pretty strong. Well, in a patient with a collagen disease, a hereditary collagen disease, the ligaments are not as strong as they should be, and the bones can be deformed just by pressures within the uterus. So babies are sometimes born with feet twisted or legs twisted in an abnormal way. These are problems that generally self-correct as children get older, but in people with collagen disease, sometimes they don't. And so this is something that we'll see in older kids and adults. It's my opinion that these things should be corrected very early on. So what do we do about this? Well, we diagnose it to start with, and this was an interesting case. The ultrasound image here is of an infant that was recognized to have deformity before she was born, and the OBGYN called me up and said, hey, you want to meet this family before the baby's born so you can start talking to them about what to expect. And that was a neat opportunity and something worth looking into. So depending on, again, when a child presents with a problem like this, that can highly influence what our treatment options are. This is the more classic clubfoot that includes not only metatarsus adductus, but also tight Achilles tendon and a more complicated deformity. Happily, I'll say that early intervention in infants with collagen disease and these deformities may have better outcomes than those who don't have collagen disease. Because we often start right off with casting and manipulation of the foot to try and make it grow into a better foot. And because the ligaments aren't fighting us too much, we can have better results. Now, left unattended and older people, this is a big problem. So we definitely want these things diagnosed and treated immediately, as they generally are in the United States. Now, some parts of the world, these unfortunately don't get proper care early on and lead to very complex reconstructive surgery needs. There are many mission trips run by podiatrists from many of the colleges that teach podiatry in this country to address those problems. So what's the prognosis? Well, if a child's born with metatarsus adductus, there isn't really a reliable way to predict how it's going to turn out. Oh, this is Michael again, by the way, in Outer Banks of North Carolina. I don't think any sharks were out that day. It was really cold, but there were some good tubes. So there he is. Sometimes if the metatarsus adductus doesn't correct itself, you get an uncompensated metatarsus adductus where the foot is still twisted, like it is in a small child when they're born. They might be more inclined to have a bunion or HAV or hallux abductor valgus. These are terms for a bunion. Might be more inclined to ankle injuries. The arch tends to be a little too high and tips over to the side. which can also stress the knee and also creates a muscle imbalance that can make the toes contract into claw shape. In a compensated one, the foot may go right past neutral and become too flat and overpronate or just flatten. This is another way in which you can get a bunion, and it creates a different type of toe deformity called hammer toe. So I don't think it's wise to just leave this alone. I think it's better off treated as an infant. My daughter, forget it, guys, carrying on. So how do we manage it? Well, some doctors recommend observation, hoping that this particular kid will be the one that outgrows it. I personally don't think that's a good idea. I don't have a way of predicting which kids are going to outgrow it. Too often, I'll have a family bring in their child who has this deformity or any pediatric deformity, and they'll say, you know, the doctor said she's going to outgrow it, and I'll look at them and I'll ask the parents to take their shoes off, and sure enough, one of the parents will still have the deformity, and I'll say, I don't know. I don't think they're going to outgrow it. Maybe we should do something about it early on. Stretching is one thing that's advocated. They'll talk about manipulating the child's foot at every diaper change to try and make the foot straighter. Stretching people who have collagen problems is kind of irrational, and so I don't advocate that in this particular population. Maybe in a child who has the normal strong ligaments, but not in people with collagen disease. Casting goes back to ancient Egypt. It was done with egg whites and linen, and is one of the mainstays of pediatric orthopedics, and is still a very useful tool for getting a foot to try and grow in the right direction. Splinting, similarly, can guide the foot and ankle to grow in the right direction, kind of like putting a stake next to a tomato plant and trying to get it to the right direction. Shoes have been used and misused in this treatment. One of the old tricks is to put the shoes on the wrong feet. This is a very bad idea. It turns out it's a lot easier to flatten a foot out than it is to get the bones to grow straight. But trying to straighten out the bones by putting the shoes on the wrong feet will not straighten out the bones and will create a second deformity by creating a very Z-shaped or skew-shaped foot. It's a bad idea. Surgery, happily, is rarely indicated and usually postponed until 8-10 years of age at the earliest, and only in those children in whom either treatment or Mother Nature took care of the problem. When we do operate, and I apologize, I probably should have warned you, there are some surgical pictures coming up, so squint your eyes if you don't want to see that. But there are some not brand new, but relatively new ways to correct this, such as the use of many external fixators to lengthen the big toe side of the foot and shorten the small toe side of the foot and dial in the correction very precisely. I might have skipped a slide. No, here we go. Okay, now talking about replacing ligaments. This is the newest thing we've gotten into, and it's been very promising in a lot of patients. So rather than counting on a patient with collagen disease, rather than counting on their ligaments to hold things together, we may be able to replace those ligaments, often through very small incisions, often without having to cut bones or break bones and realign them, and often allowing patients to bear weight promptly. This is a learning curve. These implants are not in routine use in a broad segment of the general population, and certainly not in people with collagen disease. But we have learned some tricks that seem to be pretty reliable, and we've learned some pitfalls to avoid. So here you can see, this is a guy from Beverly Hills Cosmetic Foot Surgery, which the whole concept of that just kind of turns my stomach a little bit. I mean, feet are funny looking at their best. So cosmetic foot surgery, to me, is not indicated. But foot surgery for relief of pain often is. And he's on the doctor's show here demonstrating the procedure, or one of the procedures that I've illustrated here on the right, where we've used little ropes connecting this bone to this bone, and here are 2 sets of them, and then other little ropes connecting this bone to this bone, to take that foot that was very splayed and broad and not very functional and align the metatarsal bone. So that's kind of a neat application of it that we've had some very good results and some not so good results, but mostly very good results more recently as we've learned, along with our brave and helpful patients. There was supposed to be a video right here, but John and I had some trouble getting the video to run, but you can go to a website from Arthrex, and I don't work for them, I don't get any money from them, but it's ARTHREX, and you can look up a procedure called tightrope, and it'll show you a little illustration video of the procedure. We'll skip right past that. So, here's a patient who has Ehlers-Danlos syndrome. You might recognize the shin bones, for those of you who have classic type. And you'll notice a little bend in the joints here, bone sticking out that makes it hard to be comfortable and wear shoes, or wear shoes normally. And here's an x-ray of one of the feet of this patient. And here is an illustration of a combination operation where we did actually have to take a little wedge of bone out and put a screw across there to hold that straight to realign a deformed joint. This patient got the surgery a little bit later than we would have liked. And here where we've tied the 2 bones together to make the foot more narrow, and these buttons help hold the knots so they won't pull through the bone. And this is another thing that we've invented in our program, where we use some bone anchors from the shoulder to replace the ligaments on this side of the joint to hold the toe straight. Carrying on. I'm sorry, it should be another video here, which we also couldn't get to run, but if you come to Baltimore for the meeting, we should be able to run those there. So another illustration where bone anchors have been used to hold these bones together. Ligament has been created with these other little bone anchors, taking this foot to this foot. So pretty good sized bunion, pretty deformed joint, much closer to natural anatomy or anatomical alignment. So one of the last slides here, this is also happens to be from Arthrex. We do this procedure with bone anchors from a number of different companies now, but this uses 2 bone anchors, one in the fibula at the ankle and one in the neck of the talus bone, to reconstruct a ligament that's very commonly torn when someone twists their ankle. Now, some people in the audience may have had procedures where tendons are used for this, or grafts from cadavers or from horses or any other source are used to try and recreate this ligament. But the problem is that whatever we put in there that's biologic is going to eventually be replaced by native collagen. So the patient's own collagen is going to gradually replace that implant, and it's going to fail. And it's going to tear just like it used to. So instead, using a dacron polyester webbing here and bone anchors secured into the bones, kind of like hollow wall anchors or drywall anchors to help hold those in place, can create a new ligament. And this has been used in knees and ankles in highly competitive athletes with remarkably good results. There aren't a million cases out there yet, so we don't know how long they're going to hold up. If they might need to be replaced at some point, we'll see. But for right now, this procedure can be done through that same incision where we put the little implant in that ankle, or in the subtalar joint rather, right here. And so my kind of current go-to procedure for people with collagen disease and feet that flatten out too much and they roll their ankles frequently is to combine implantation of this joint with a subtalar arthroereisis device and reconstruction of this ligament with suture material all through an incision about 1 centimeter long, little S-shaped incision. And that's been a pretty exciting innovation that has helped a number of our patients. and then sometimes going up to the big toe and straightening up that joint at the same time. So that's the end of my canned comments. I see we're up to about 42 questions now. I don't know how many we'll be able to get to, but I'll just move on to our questions and answers now.
Thank you, Dr. Agnew. If you click on the Q&A icon at the top, you should be able to open the list.
Okay, very good. So let's go right up to the top of the... Okay, the first question I'm going to defer. This has a lot of questions about Chiari malformation and POTS, and I would refer that to another specialist. We do have a Chiari center here at our Children's Hospital at King's Daughters, but that's outside of my scope of practice. Next question. This patient severely sprained her ankle a year and a half ago and realized that the ankle and foot is still swelling at this point. Is that normal? No, that's not at all normal in any patient. Ankle sprains are the most common injuries in the United States. And about 10% go on to some chronic disability just in the general population. They tend to be overtreated because they're so, undertreated because they're so common. People will get, crutches and an ace bandage, and most of them will get better. But what about those that didn't? So anybody who's had pain and swelling beyond 6 to 12 weeks really needs a doctor's attention. I'd say anybody with collagen disease who twists their ankle enough to cause swelling or inability to bear weight really needs to get to a doctor and be properly evaluated. And you get into that 12-week range, they probably need a more sophisticated image. There's a thing called the Ottawa classification, which helps emergency room doctors decide whether or not they need an X-ray of a sprained ankle. If they've decided to do an X-ray, more often than not, it'll look normal. But special X-rays like stress film and MRI pictures can often reveal occult injuries that might not be seen on an X-ray, but might be very important to the outcome. For example, damage to the cartilage on that talus bone inside the ankle, or ligaments that are supposed to hold the tibia and fibula together that are unstable and stretch and create a chronically unstable ankle. So no, that is not normal. You should seek some help for that. Next question. Let's see. Well, this one's kind of long. Let's see. Patient had surgery for a tethered cord, and ankles became hypermobile afterward. There's some questions about central nervous system problems and surgery for that. Again, that's outside of my scope. I'm not going to touch on that except to say that people who have neurologic problems or degenerative nerve or muscle diseases, generally, whatever's wrong with the foot will get worse. So when I'm teaching my residents about foot and ankle implications of neuromuscular diseases, I tell them, whatever, if the foot had too high of an arch, it's going to get higher. If the foot had too low of an arch, it's going to get lower. If the ankle was too tight, it's going to get tighter. If it was too floppy, it's going to get looser. So the onus to treat is more intense in people with neurologic or muscular disease, and I would include tethered cord syndrome in that. So there's some specific questions here about rehabilitation and so forth. For that, I'm going to skip past this question, and I do apologize to whoever submitted the question, but I'm going to try and get to something that hopefully will be more germane for a broader audience. Oh gosh, I think I skipped back a whole bunch of questions. Okay, here we go. So, plantar fasciitis, is it possible? Yes, and that surprised the heck out of me because I figured if all your ligaments are stretchy, why would one of them tear? Now, plantar fasciitis is the most common complaint that most podiatrists see in their practice. It's pain on the bottom of your heel when you first get out of bed in the morning. And it's not well understood, surprisingly, especially since it's such a common thing. So there's this ligament on the sole of your foot that's supposed to hold your arch up, and that ligament gets damaged. Now the disease is misnamed. It's not actually fasciitis, it's fasciosis. Fasciitis, or itis, it implies inflammation, like rhinitis, conjunctivitis. These are inflammatory things. Now, an old professor of mine up at Temple University in Philadelphia took biopsies of the plantar fascia and published in, of all places, Scientific American back in the late 90s, that the biopsies did not show inflammation. It showed stretching, tearing, scarring, but not inflammation. So a lot of people will treat heel pain with anti-inflammatories, and it may make it feel a bit better, but it's really just acting as an analgesic. So a cortisone shot or a pill like Motrin might make a patient feel better, but it isn't going to solve the problem, and usually it comes back. So we use more mechanical means like splints that you wear at night, arch support with statistically very good outcomes, and we try to actually cure the problem. It's probably a little harder to treat in someone with collagen disease because, again, you're expecting a strained or stretched ligament to actually heal, which is hard enough, but even harder in a collagen disease patient. So, but it is treatable. So next question. Patient saw a podiatrist and was diagnosed with an extreme flat foot, and they use some of the scientific terminology here. Let's see, the doctor's impression. Oh, also noted ankle instability. I'm sorry, for some reason when I click on these questions, they don't move down very fast. Maybe because people are still adding questions as we go along here. I'm trying to get the rest of the story.
Are you clicking on the arrow or you may not want to use the scroll bar. It might move too quickly for you.
Yeah, well, I'm clicking on the I'm clicking on the arrow down, and the words don't move at all, and then they move all at once. So it's just lagging. But sooner or later, I'll get to read the rest of this patient's story. Let's see. I'll try
if you get to the point you need assistance, let us know.
I think I need assistance. I'm scrolling all over the place, and it's not moving. So feel free to take it over here.
Okay. John, do you have access to the questions?
Yes, I do have access to the questions. And
okay. If you want, you can give me access if you'd like for me to try to read those, or whatever works best for you.
I can't wait to hear what happened to this patient with the flat feet and bad ankle.
Okay, you should have access to the questions.
Okay, let's see if I can
there,
find
it just jumped forward all of a sudden.
Okay.
So we're back up to the top. Okay, so this patient then, they're asking me what would I do about this? So they also go on to say that the talus in both feet is actually dislocating in a resting position, which happens, and that patient's toes are becoming crooked as a result. And we talked earlier about how that happens, and this hurts a lot, and what can we do about it? So some of the things we talked about, like bracing, splinting, are definitely worth trying. The patient had already had good shoes, orthotics, and physical therapy without satisfactory outcomes. So this patient might be a candidate for something like we talked about earlier, like a combination of subtalar arthroereisis and ankle stabilization using synthetic ligament. So probably a very good candidate for that. Someone else said thank you. You're welcome for for being on the chat tonight. That's somebody I know. Hi. It's like when your mom calls in a radio show. Let's see. All right, I'm scrolling again and nothing's happening. I don't understand why it's lagging here. Up, and there it jumped again. Okay. I have to scroll back up a little bit. I apologize. There are a lot of questions here, and we're not going to get to anywhere near all of them. But, okay, next question. Everyone talks about flat feet and Ehlers-Danlos syndrome, but I have high arches, which are collapsing, and I have a lot of pain, including plantar fasciosis. It says plantar fasciitis, but I want everyone to learn that word, fasciosis, because that's actually what's happening. Is this common with hypermobile foot type? Absolutely. So remember, you could be born with a high arch foot, but if the ligaments aren't holding that arch up properly, the foot will go right past neutral and become too flat. And that abrupt change from too high to too low is the worst. That's the foot that hurts the most. So this patient's already had ankle braces, hinged Langer AFOs, and is still having a lot of pain and instability. So what do we do about that? Well, sometimes that might be again, a candidate for surgical treatment, such as the subtalar arthroereisis, which seems kind of crazy in a patient with a high arch foot, but remember that high arch is going to go right past neutral and become too flat. And let's see. And now it's not scrolling anymore. Oh, there we go. So now I'm all the way to question 52. You know what I'm going to do? I'm going to start at the bottom and work my way up. Maybe that'll work better. So, say again? Deanne, what did you say?
That sounds like a good idea. Let me know if you need
me. So this says, do you have any suggestions on how to locate a podiatrist who's up to date on the newest treatments for EDS? So that's hard for any specialist because, this condition, this group of diseases is not well recognized. It's probably a lot more common than we think. I know back 25 years ago when I got interested, they talked about it occurring in somewhere between 1 in 150,000 to 1 in 750,000 live-born babies. So that's a pretty broad range. And a lot of patients I'll see for totally unrelated issues, and I'll find out that they have hypermobility and maybe even a collagen disease. You have to look. We always tell our surgeons we want them to have screwdrivers and hammers so they don't just hit everything. Sometimes you got to twist something. You have to know the potential for a disease exists to actually look for the disease. So a lot of people have seen it and don't realize they've seen it, or they can't figure out why this one patient won't get better with the stuff that usually works. So your best bet, I think, is to always, when you have a rare disease, find out who's doing the most with that, and then find a local provider who's open-minded enough and doesn't have too big of an ego to call that national or international expert and talk to them about you. Talk about the case. And if need be, even send you to where that doctor practices. We've had people come to my practice from Norway for foot surgery and all over the United States. And we don't suggest that you have to come to me to get these procedures. They aren't that hard of procedures to perform. And I'm very happy to talk with doctors anywhere in the world about what our experience has been and see if the patient can get local treatment. And when they can't, we're well set up at our institution to take people from out of town. So that's an option. Okay, going up to the next question here. Another one about plantar fasciosis. If it's tolerable, can I ignore it, or will I do more damage in the scope of various pain? This is low on my list. Fair enough. So, yeah, sometimes you have to pick your battles. Walking around with heel pain, I don't think leads to any other problems except possibly the avoidance of physical activity, which does have long-term consequences like obesity, bones getting softer, depression, loss of will to live. There are consequences to not moving. The human body is designed to move. So if you can move, you should. And if your heel pain is keeping it from moving, it's usually treatable. Someone asked about platelet-rich plasma injections. Do they work? Well, we use them fairly routinely in heel pain and in torn tendons and ligaments. So I think they're very useful in some patients. I don't have any data on their efficacy in people with collagen disease, but I would be a little bit dubious because what you're using there is the patient's own platelet-rich plasma derived through centrifuging their blood in the operating room and then injecting it into a tissue in the hopes that it will heal. Well, remember that tissue is always going to heal with the same kind of collagen until someone comes up with gene therapy and a way to make new collagen, better collagen. And so it might provide some good results or enhanced results, but we're still relying on that native collagen that's already failed once. So I wouldn't be overly optimistic. Next patient here is talking about can an MRI show stretched ligaments in the ankle? Sometimes yes, especially when they're acutely injured. An MRI combines both anatomy and physiology images, which are very interesting and useful to us as surgeons. And it can show what ligament looks like statically, whether it's too thin or too thick, whether it's longer than it should be. So yeah, it can help the information there. If it's been acutely injured, it might contain edema or swelling, which can be very clearly seen on one of the types of MRI images. So yeah, an MRI sometimes can show that. Now, you often need very small coils, which are used to look at smaller structures. So some basic MRI centers might not have those more sophisticated, what we call extremity coils. And you want a musculoskeletal radiologist to look at it. If they don't have one in your local town, images can be emailed to a center where someone can look at them and read them properly. But we rely heavily on them, and I always look at them myself. So if you've had x-rays, MRIs, CT scans, bone scans done at another institution, I'll usually ask you to bring them to me with your CD when we evaluate you, and I'll keep them for a while and look at them and see if I agree with the radiologist, because sometimes I'll have a little bit different perspective on it as the foot and ankle specialist and surgeon. Next patient said, I have chronic pain on the bottom of my foot, and bone and joint specialists marvel at the lack of fat pad in my foot. Do you see this often? I literally have none, and basically the bones are made contact with the ground. Yes, sadly that does happen in some patients. The way that your fat is kept underneath your heel is with ligaments. They're formed in little cylinders like a mattress, like the springs of a mattress. So if those ligaments fail, the fat can kind of squirt out to the side and isn't underneath your heel where you need it, and can even create little lumps around your heels called iusogenic papules or pseudotumors. So the fat's in the wrong place. This has been one of the problems with fat replacement type surgeries here. One of my old professors back at Temple back in the 80s would take fat out of someone's stomach with a special machine and inject it into the heel, and the heel would feel great for weeks or months, and then the fat would kind of just leak out and wind up in the wrong place. Same thing could happen with other soft tissue fillers, Restylane, plastic surgery fillers. They don't stay where you want them necessarily because of the lack of ligaments to hold them in place. So tough situation. Now there are some devices designed to address that. There's a thing called a Hellfelt heel seat. I don't know how to spell Hellfelt. You have to Google it, but it's a polypropylene cup that sits under the heel. I'm sorry, that's an MS heel seat. The Hellfelt's a different thing. MS heel seat is a polypropylene cup that you put in your shoe and you sit your heel in it, and it just kind of holds the fat underneath your heel where you need it. Another thing, again, is disuse atrophy. The human body is designed to move. Everybody in the audience must exercise. how you exercise is a decision between you and your doctors and therapists, and has to be carefully designed, but the human body needs to move to work right. Another patient here had a modified rostrum procedure. That's an ankle stabilization procedure where the ligaments are cut and then sewn in a pants over vest manner to try and keep the ankle from twisting. And the patient goes on to say, with an internal brace, a little more than a year ago, the joint is much more stable, but I still have constant pain. There's a little sharp bit sticking up around the incision. These are painful. Any ideas? So this could be some sort of a reaction to suture material, or maybe the bone implants aren't deep enough into the bones to not be felt. One of the old adages about ankle stabilization is that you can turn a loose painful ankle into a stiff painful ankle. They don't always solve the pain issue, particularly if there's been damage to the cartilage in the joint or damage to the synovium that lines the joint and lubricates it. So simply tightening an ankle doesn't necessarily alleviate pain. So there are probably other reasons for the pain that need to be investigated further. So back to the drawing board, this patient needs a new MRI and possibly arthroscopic examination of the inside of the ankle, because there are things that the MRI will miss that we'll often see with an arthroscope. And they do have small pediatric arthroscopes that we can look around inside the ankle of an adult without doing any further damage, and we'll find little problems that we can sometimes solve. So excellent question. And a good point about ankle stabilization, that it doesn't necessarily solve all the answers. Okay, here's a patient that says, how does a sunken arch affect the alignment of the upper body? Do you recommend most EDSers wear orthotics for their sunken arches? I like that term, sunken arches. I might steal that. I have trouble fitting shoes due to both comfort and fit. I have a very narrow heel and a wide ball of foot. That's commonly seen when I bear weight, and my arch flattens and footprint widens. I currently wear wide men's tennis shoes. This is a female patient. I have trouble wearing even no-heel dress shoes. Do you recommend certain types of shoes or brands to try for an EDSer like me? So the combination of the narrow heel and wide forefoot is a challenge, and common in people with hypermobility with or without diagnosed collagen disease. And it tends to get worse over time. The average American's foot gets wider about one width every 10 years. So if you were born an A, you're going to be an E by the time you're my age. And that makes it difficult to find shoes that fit both ends. There are some brand names that have a good reputation for having lots of room in the forefoot, like New Balance and Brooks. But bottom line on shoe brand names is that they are all made from a theoretical ideal at the shoe factory. And so if you go to buy a size 10D shoe, each manufacturer is going to have their own idea of that. There's a place in Rockville, Maryland called the National Bureau of Standards. So they have a standard meter made out of titanium. They have a standard kilogram made out of titanium, and they loan these out to universities to do measurements. But they don't have a standard size 10D shoe. So whatever your shoe manufacturer thinks it is, that's what their version of the size is. So rather than recommending a brand name, I'm going to recommend some things to do. Buy your shoes at the end of the day. Your feet change, often a size, and in people with POTS or collagen disorders, maybe more through the course of the day. So if you buy your shoes in the morning, they'll be too tight by the evening. Buy your shoes from a store that will allow you to take them home and walk around in them for days or up to a week or two at a time on carpet so you don't damage the shoes. Wear them maybe an hour the first evening, between supper and bedtime, 2 hours next evening, 3 hours next evening. Don't wear them outdoors for a whole week. Don't exercise in them for a couple of weeks. So those are some good tips, I think, on buying shoes for everybody not just people with collagen disease. This patient also asked about whether I recommend orthotics. Yes. I think anybody who's diagnosed with collagen disease, that's one of the very first steps. I saw a question higher up a while ago about custom orthotics. So again, orthotics and biomechanics is a lot more art than science. So I can't give you good scientific recommendations on a particular type of orthotic or whether rigid is better or soft is better or a combination. It's a case-by-case decision making. I think you need an arch support that's going to hold your arch up without hurting you. And that sometimes takes a little experimentation and a little experience by your provider to come up with something suitable. And sometimes it doesn't work. So, swelling in the feet and ankles keeps reoccurring. EDS or dystonia. I can't pronounce that word. So, POTS, dystonia. I think that the latter is the case. Blood vessels contain collagen also and can get stretched out of shape, and fluid shifts from top to bottom, going to go downhill, and swelling is not an uncommon finding. Although swelling in your ankles can come from a whole lot of different sources: kidneys, liver, heart, lungs, bad veins, collagen disease. So it needs to be properly diagnosed. You need to see a primary care physician to be properly worked up. What are my thoughts on chiropractic adjustments? Outside of my scope of practice, I've heard a whole gamut from great to not so great. I think that that's where you rely on your local support group and you see what kind of results others are having. I would not talk anybody out of it, but I would have a nice long talk before the chiropractor puts hands on your back and starts moving things around. And cervical spine x-rays, and those I think are all wise before it's going into any kind of manipulation. Do I know any doctors in Northeast Florida that do ligament replacement? I don't know right off the top of my head anybody in the country who's doing much of this. This is new. We're doing, I think, the most in our region. The guy who invented this concept is at Rice University. So that might be helpful to some people. There's another guy in Phoenix that does some of it, and I can talk about those particular providers offline. I don't have their contact information at my fingertips. Let's see. Is the subtalar arthroereisis a commonly used procedure? How can we find doctors who do it? And do you know any podiatrists in New Jersey that are knowledgeable about EDS? So subtalar arthroereisis has waxed and waned in popularity. Some doctors looked at it as like a cure-all right away and put them in too many people and got some bad results and got scared away. Some doctors have never done it and will condemn it on theoretical basis. So there's a broad gamut there. I know some of the manufacturers of some of the devices can be contacted, and they can probably steer you towards people they know in their community who have the most experience. As far as using them on people with collagen disease, there isn't really anything adequate published. So it's a little bit of a gamble. Every time I put one in, generally that gamble's been rewarded with at least improvement in patients we've used them in. Let's see, moving along. In Northeast Florida, no, I can't name anybody off the top of my head in that area. Move up a little further. Is arthroereisis for the subtalar joint an option that could be eliminated if the joint is too degenerated? Yes. Degenerative joint disease of the subtalar joint is a relative contraindication to the procedure. I will say we've done it in some patients who have had pre-existing subclavicular joint disease. We did it as a punt to see if we might be able to avoid fusion, and in many of those patients it's been successful. One of the nice things about that procedure is I can unscrew it. There's not a lot of things in life I can unscrew, but if I put that in and it bothers you, I can take it back out. So if there's not too advanced disease, it can be reversed with little to no harm. And so I think sometimes it's worth a try, even if there already is degenerative joint disease. Patient and surgeon need to go in eyes wide open. Here's another question. A patient, let's see, I think my headphones are about to run out of batteries. Stand by.
We can still hear you.
How's that? You still good?
Okay. Yep, that's good.
Okay. Yeah, my little hands-free handset ran out of battery. Okay. So this patient's asking about first metatarsal.
Okay, sorry about that. I think we lost him. I think his battery did die, so he'll be back in just a moment. Bear with us. Sorry about that delay. And hopefully just a moment or two, and we'll have the doctor back on.
Well, as we're waiting for the doctor to come back on, just wanted to remind people that if you are planning on going to the EDNF conference in Baltimore, please stop by to see us. We'll be giving a presentation, and the doctor's coming back on. And the doctor will also be giving this presentation. So, welcome back.
Thanks for filling the dead air there, John.
Okay.
I had to reconnect after unplugging my headpiece. But okay, so this patient was talking about first metatarsal toe joint popping out of position on weight bearing. Sometimes pops out at night. The patient will pop it back into position by pressing on her foot. Usually, the surrounding tissue is painful during these flare-ups. Typically, it's very painful when the water pushes on it during gentle swimming, and flare-ups occur during periods of increased walking. The other foot is becoming painful recently, but less popping. Is there an orthotic for this, or is there a taping technique to stabilize the joint during times of more activity? Are there any activities to avoid? Am I loosening the ligament by popping it back in? Well, you're certainly loosening the ligament by popping it out, and if it can pop out of a joint like that, it's probably already loosened beyond serviceability. So this is something that will keep happening. And every time any joint pops out of position, the cartilage on the surfaces of the joint can be damaged. So that's worrisome and probably needs to be addressed. I'm not aware of any kind of splint that's available for that you can walk around in. There are splits that we use after bunion surgery to try and position the foot better. Someone there said the sound is very low. I hope that's better. I'm just talking louder now. So these splits are designed for use after bunion surgery and can be useful to maintain the position of a joint that's been surgically repaired. As far as walking around in them, they're pretty cumbersome to fit into a shoe and they're restrictive of normal movement. So not the best option there. I wish someone could come up with something like the finger splints that people have invented for people with Ehlers-Danlos syndrome. I wish I could tell you who did that, but I think it's the most clever thing. They're works of art to hold fingers straight. Feet, not so much. Haven't really seen that done yet, but I hope someone does come up with an idea on that. What we're currently doing is replacing the stretched ligaments with bone anchors and suture material. And we're hoping that's going to hold up long term. So that's the story on that. Taping techniques might not be a bad idea. Certainly would talk to a physical therapist. Maybe they can use some, or occupational therapist, maybe could use something like kinesia tape, or teach you how to use it yourself to try and keep the joint in place. But allowing it to pop out of position, popping it back in repeatedly is going to be damaging. Next patient was asking about, do severe pigeon toes, which were corrected with long-term braces, have anything to do with collagen disease? I think we talked about that in the talk. We were talking about metatarsus adductus. That's one of the things that can make toes kind of point toward the midline of the body, or what's sometimes called pigeon toes. And yeah, they are certainly associated with collagen disease. Next question is, someone's already had significant arthritis in their ankles. I do, and I'm only 29, it says here. What can be done to help? Am I just doomed to chronic severe pain in my ankles? So I have some maybe exciting news for you. There's this whole new field of regenerative medicine. We touched on it talking about platelet-rich plasma injection. That was one of the earlier forays into that. But there are some new concepts of trying to cause tissues that don't usually heal, like cartilage, to heal better. One of these is the use of fetal membranes. These are not from abortions. These are donated from after birth, from donor moms who've been screened for diseases. And in some cases, these tissues are sterilized with radiation. And they're usually only taken from moms who had C-sections, so there's no disease that could be picked up vaginally. And these tissues are special because they contain the right kind of collagens to build things like cartilage, tendons, ligaments, and they're privileged immunologically because they're designed not to be rejected by the baby or the mom. So these are currently FDA approved and available for things like diabetic foot ulcers, venous leg ulcers, bad burns, and they can set up a trellis with growth factors and collagen to replace damage to skin. They can also be used inside of joints, tendons, and ligaments to try and cause those tissues to actually heal. And these are not yet FDA-approved uses, but there are research projects. We're doing one in our practice right now on plantar fasciosis, and you'll see more and more of that. Professional athletes are paying cash for these things already to try and get their ligaments and tendons and things to heal fast and more completely. So there might be a way to get some of the surface of the inside of your ankle better. Ankle joint replacement with artificial joints is, in my opinion, still kind of immature. There are better and better implants coming out every year, and surgeons are getting more and more experience with them. So ankle joint replacement is not out of the question. It's not that you're very young for that. You would not be a candidate probably yet. They're definitely not at the levels of knees and hips. And using them in people with collagen disease is going to be particularly challenging because usually you count on the ligaments around the joint to hold the implant in place while the bone matures. So big challenges there. But you might want to look into regenerative medicine for a bad ankle. And you want to stop the ankle from slipping out of position by whatever means are necessary, whether that be bracing, muscle strengthening with physical therapy and rehabilitation, or maybe ankle ligament replacement. Next question, can diagnostic techniques like MRI be done after an implant of a metal device? Yes, if the device is titanium. There's no contraindication. Unfortunately, they do distort the images, so they're not quite as valuable, but they still can be used. And sometimes CT scan is a better choice in those cases, but most of these, or many foot and ankle implants are made of titanium now for that very reason, so that we can still do MRIs. Titanium is a non-ferrous metal, so the magnet's not going to rip the implant out of your foot. Here's a person with a 16-year-old who has worn orthotics for that patient's entire life. Her feet are flat. She has bones sticking out and hammer toes. Doctor says she'll need surgery to fix these toes. Is this a good idea with EDS? I'm going to say probably yes. You know, that's a bit of a guess without actually examining your child, but generally a 16-year-old woman, the bones are mature, they're no longer growing, so the likelihood of success is better than a younger child. These deformities are not going to go away by themselves, and correcting them at an earlier age can be a really good idea. And then correcting the flattening of the arches might be essential, or any treatment of the bunions and hammer toes is going to fail. The reason you get bunions and hammer toes in the first place is because the foot flattens out too much, and the muscles that pull on the toes pull the toes into abnormal positions, and then the bones adapt to those abnormal positions over time. So if you don't control the overpronation through orthotics or possibly surgery, then any forefoot surgery like bunions and hammer toe surgery is going to fail pretty quickly. Next patients on a similar line, over the past 5 to 7 years, have been experiencing toe clawing that caused a lot of pain and had the tips of the at the tips of the toes. The patient's seen 4 different foot specialists, had 3 different pairs of custom orthotics, but nothing has worked. Can you suggest any other approach to try? I will probably recommend surgery. Now, some exciting advances have been made in toe surgery, specifically indwelling implants. These are little devices that go inside the bone marrow cavity of the toe bones to hold them straight over the long term. One of the older approaches to hammer toe surgery is to use wires that are passed through the end of the toe and then back into the foot, and they sit there for 6 weeks or so. Long-term results for those are mixed. Sometimes the bones will fuse together and the toes will stay straight. Sometimes they don't. They can do all kinds of weird things over time. And so people have thought up different types of implants to stay inside the toe permanently and try and get the toe to stay straight long-term. These are relatively recent innovations, so long-term results aren't available, but our experience in using these over the last, I'm going to say 6-7 years, have been very satisfying. And we no longer have these Wolverine-looking feet with a bunch of pins sticking out of them for 6 weeks. So that's something that our patients seem to really appreciate, and results so far have been very promising. Let's see. Next patient. Often the bottom of my heel is tender in the mornings. Stretching my calf has always helped, but now I'm nervous about stretching. Recommendations. So yes, this patient might wear a splint while sleeping at night to allow the injured tissues to heal in a functional position, so that when she gets out of bed in the morning and puts her foot down, she doesn't have to hurt herself to do so. So there's an idea. Next patient. What's the safest way to stretch a short, tight Achilles tendon? So you really need the guidance of a therapist or a doctor to do that properly. Not something we probably talk about over the phone here, but something that definitely needs to be done properly to avoid further injury. Another question up here about platelet-rich plasma and healing partial tendon tears. So a little bit of good news. Tendons are made out of different materials than ligaments, and often people with collagen disease can have terrible ligaments and not so bad tendons. And so maybe that is a place where platelet-rich plasma would be advantageous in stimulating healing. We use this routinely in our general population to try and encourage tendons to heal because when the tendons don't have a lot of living cells in them and don't like to heal in the first place, so we like to nudge that along with sometimes things like platelet-rich plasma, and we'd like to more and more use things like fetal membranes that we talked about a little bit earlier. Next question. I get cysts on the tops of my feet and inside of my foot about an inch in front of my ankle bones if I wear supportive shoes such as sneakers, so I avoid them and feel happiest barefoot, weather permitting. Is this typical of EDS? No, not at all. Not at all typical. You are generally advised to wear supportive shoes. I'm not sure what you mean by cyst, so I think I'm going to skip over that question. I really don't have a good explanation for your experience, but I guess I'm kind of happy for you. I mean, who wants to wear shoes all the time? But often you need to. Shoes are kind of a necessary evil in North America. I don't know if that patient's closer to the equator, but we need them in this country. Next patient. I've had 3 surgeries on my left ankle so far, and most recently in June 2015. Are there any specific things to help prevent needing surgery due to breakdown or defect in cartilage? I'm concerned that I will need further surgery as I continue to walk on my feet and my cartilage continues to break down. So this patient, again, might seek out someone who's working in regenerative medicine. Gosh, that's a terrible Freudian. Regenerative medicine and ankle stabilization. So if the ankle's still slipping out of position, it doesn't matter what's done, the cartilage is going to get damaged repeatedly. Next patient. This patient's daughter has EDS type 3. We don't use that terminology any longer, but has understandably severe pronation of both feet. She has experienced several stress fractures. Interesting. Do most with EDS share this trait? And what non-surgical means can be used to manage this pronation? So overpronation, yes. Stress fractures, not so much. Your daughter probably needs vitamin D levels tests and a bone density scan and may need super nutrition with extra vitamin D. Also, and I wouldn't just jump into that. Vitamin D is a fat-soluble vitamin, and overdoses can occur. But again, in North America, most people are probably vitamin D deficient. I mean, we're designed as humans to walk around the equator foraging for food all day, getting exposed to sun all day. We live in places under artificial lights and limited sunshine, and so we're probably all vitamin D deficient, which can also affect your mood and make you grumpy, which might explain a lot. But having, we're in the South here in Virginia, so we're not as grumpy as some, but we probably all need a little bit more vitamin D, so that'd be worth measuring and possibly treating. And then the idea of a misdiagnosis should be entertained. There may be that your daughter actually would have a form thrust of osteogenesis imperfecta. I'm not sure that would change my recommendations, but revisiting your diagnosis might be reasonable. Next question. Shoes need to be perfectly aligned or they cause me pain. How do I detect the less obvious problems? I'm not sure what you mean by that. As far as shoes being perfectly aligned, we spoke earlier about how to select shoes. End of the day, get permission to return them if they're uncomfortable. Those are definitely wise decisions. And if the shoe store won't let you do that, go to a different shoe store. Shoe stores are popping up everywhere. And very sophisticated shoes are routine now. So finding a shoe that fits is much more possible now than it was 10 years ago. Next patient has classical EDS, has been struggling with ingrowing toenails. Okay, here's something different. For quite some time now in the past, I could get rid of symptoms by soaking my feet in Epsom salt. At this point, if it is no longer working, I'm aware of the procedure to remove ingrowing toenails, but like many EDSers, local anesthetics don't work for me. Do you have any suggestions for alternative alternate anesthesia options for the removal procedure or alternate treatment options? Yes. Okay, excellent question. So why do you get ingrowing toenails? So they're not particularly more common in people with EDS, but they are fairly common in people with abnormal foot anatomy and physiology. If you have a foot that tends to flatten out too much, the sides of the toes may touch the ground and the shoes in ways they're not supposed to, which might cause the ingrowing toenails in the first place. So you might have excellent surgery on the toenails and your toes might still hurt if the foot's not properly aligned. So it's very important for your provider to recognize that issue and address it. Ingrowing toenail surgery works just as well on people with EDS as anybody else. The offending part of the nail can be removed. The corresponding nail bed can be destroyed with anything from radio frequency transmitters to lasers to most commonly an acid called phenol. But destroying the root's not the hard part. The hard part is, as you point out very accurately, is anesthesia. So local anesthesia is a problem. I don't know why. My theory is that the little ligaments that are supposed to hold the skin to the deep fascia through the fat pad fail. These are called Langer's anchors. And if your Langer's anchors don't work and we put local anesthetic into that fat layer where the nerves are, it probably leaks out. It goes everywhere except where you need it. So, clever new innovation is liposomal bupivacaine, brand name Exparel. I'd love to hear some feedback, and I'll be asking people in Baltimore next month about their experience with Exparel. We've used it on collagen patients postoperatively to try and give a longer-term pain relief. It's supposed to last something like 2-3 days. My hope is that combining the local anesthetic molecule with the fat molecule will allow it to stay in place longer and get better results. So you might ask the toe surgeon about Exparel, and you can have toenail surgery under general anesthesia. It's pretty rarely necessary. We do it with special needs patients, people with Alzheimer's spectrum diseases. I'm sorry, not Alzheimer's. Gosh, I've been talking so long I can't even think anymore. But people with Asperger's who might not sit still for toe surgery. We sometimes use general anesthesia. But using Exparel in patients with collagen disease is something I'm a little excited about and looking forward to gaining more experience in. And I'm hoping that experience will be much better for those patients. Thoughts on midfoot fusion for treatment of EDS-related severe metatarsus adductus deformity. So my feelings on midfoot fusions for metatarsus adductus is that it's not often necessary. I think it's possible to do osteotomies instead of arthrodesis. I think osteotomies in the midfoot are the best place to treat metatarsus adductus. There are osteotomies designed to work on the metatarsals. These often involve cutting 5 bones and trying to line them up perfectly and hoping you get a good result. With each procedure, you have a risk of failure, certain percentage risk, 1%, 10%, depending on the procedure. So you do 5 procedures and you got 10% times 5. That's a pretty high risk of failure. If you instead cut the cuboid and the navicular, the cuboid and the medial cuneiform, or maybe the medial and intermediate cuneiform, the foot can be aligned with osteotomies instead of arthrodesis, and you're only cutting 2 or 3 bones instead of 5 bones. That's my preference, and there's a chapter I wrote in a book called The Comprehensive Textbook of Foot and Ankle Surgery by Montgomery that talks about this in a lot of detail. I've had bad arthritis in my big toe. I very often hear that EDS patients are bad surgical candidates. How successful do you think surgery would be to replace that joint? So, yeah, historically, orthopedic surgery in general for people with collagen disease has met with a lot of failures, but I think we've talked in some detail already this evening about possible treatments for that. So avoiding arthrodesis, not counting on ligaments. I think you can have very good outcomes with foot and ankle surgery for people with collagen disease, including that big toe joint. If you got to have arthritis, that's the right place to have it because there are dozens of different ways of treating it, from brand new ideas like regenerative medicine to slightly more experienced ideas like osteotomies. And joint replacement has seen some recent innovations at the first metatarsal phalangeal joint or big toe joint. So I wouldn't rule out surgery there, but you could maybe even try some other things like having some placenta membranes injected in there. Next line, in order to discover any foot and ankle issues, should I be seeing an orthopedist, podiatrist, or orthotist? Excellent question. The answer is any and all the above, and ask around and find out who does it the most in your town. One of the biggest mistakes in medicine is to pick your doctor based on the letters after their name. That's kind of like bigotry. That's kind of like picking a doctor based on where they go to church or what color their skin is. I think instead you need to ask about their experience and knowledge. And in some towns, the local orthopedist will be the most experienced foot and ankle surgeon. And sometimes it's going to be a podiatrist, and sometimes you'll have two in the same practice that work together. So I think you got to do your research. And orthotists, experienced orthotists, are invaluable to any of us surgeons. My calcaneus tips laterally, causing pain and swelling. Prolotherapy has not been very successful. What else is there to treat the problem? I would love to talk to more people who've had prolotherapy. I'm hearing mixed results with people with Ehlers-Danlos syndrome. I think it's in many cases worth trying. I do wonder about the long-term outcomes because, again, what you're doing with prolotherapy is trying to get the patient's ligaments to heal. And if their collagen's no good to start with, I'm not sure what the long-term effects are going to be. But it doesn't burn any bridges. It hurts a little, I hear, but I'm hoping it'll be effective in allowing people to gain some time and to choose other options later if they need to. As far as treating the calcaneus tipping over, that more than likely is subtalar joint instability. And we've talked already this evening about some ways of addressing this with subtalar arthroereisis plus or minus ligament replacement. What's my opinion on removal of hardware in the foot following failed bunion surgery years ago, prior to EDS diagnosis? Ongoing pain, numbness, but concerns questions as to whether removal of the hardware would be worth the risk of surgery. So, too broad of a question, I'm afraid. The type of hardware would have a big influence on the decision, whether or not every other source of pain and numbness has been ruled out. One thing I do worry about is whenever somebody talks about numbness, I get concerned about nerve damage. Nerve damage, once it gets past a certain point, isn't reversible. So if you break your neck, it's broke. If a nerve in your foot is getting chronically irritated by proud hardware, for example, or hardware that sticks out too much, sometimes taking it out sooner than later can be a good idea. We do not routinely remove hardware just for the sake of removing the hardware in the foot and ankle. Some surgeons do. I don't think it's necessary. There's a legitimate concern about the hardware causing weakening of the bones around it by its ongoing presence. We try where we can to use the smallest effective hardware to address that issue, and we do not routinely remove it. Next person has a daughter, 17-year-old, that has EDS hypermobility. She wears orthotics. About 2 months ago, her ankle started hurting. When she walks, the ankle rolls. An ultrasound showed thickening, swelling, inflammation of the posterior tibial tendon with no swelling in the joint. A cold compress, a hot bath, Voltaren cream have given her minimal relief. She does stability strengthening PT exercises 4 times a week. What other suggestions do you have to improve the ankle pain and looseness? So we've talked about some things to stabilize the ankle surgically. I think you're already doing a lot of things right with the physical therapy and the icing and the topical anti-inflammatory. I think she needs an MRI. Posterior tibial tendon injury is relatively rare in a 17-year-old, even with Ehlers-Danlos syndrome, and wouldn't happen in a vacuum. It wouldn't happen all by itself. There would need to be some reason for it, such as subtalar joint instability, and we've talked quite a bit about what we do about that. There is a brace you might look into called a posterior tibial tendon brace. It's made by Aircast, and it looks like a standard ankle brace. It's black with Velcro straps and just stays on the sides, but it has a little balloon in the arch that can be pumped up with a little hand pump to create a little bit better arch. So there's an option. Let's see, moving up a little bit. When I lay on my back, my feet roll inward. I often find myself laying this way with my feet facing inward and one set of toes resting on top of the other. Is this normal or a hyperextended position? Hyperextension, hyperflexion, that gets into some complicated anatomical classifications, but no, your feet should pretty much point straight up in the air. So if they're kind of twisting toward one another, that means some joint is not in its optimal position. Is that necessarily pathological or is that going to cause problems? Maybe. Sometimes if you get out of bed in the morning and your joints are stiff and painful, positioning your feet while you're sleeping with braces can be a good idea. Any joint that's allowed to rest in an extreme position outside of its normal range is probably doing damage to the ligaments and cartilage. So I don't think that should be completely ignored, but I think there are a few more questions that need to be answered. Next question. I can walk on even pavement without problems, but walking on grass or sand causes painful misalignment of my ankles. How common is that, and any suggestions? So that is extremely common, and it's more than likely not actually your ankle, but the joint just below it, the subtalar joint. That's the joint that's responsible for adapting to uneven surfaces. Your ankle joint kind of just goes up and down. The subtalar joint goes more side to side in a complex corkscrew movement called pronation and supination. So if that subtalar joint is not working within its normal function, then walking on uneven surfaces can be very challenging. It's another reason why I don't like fusing that joint if I can avoid it. So having something, some intervention to make that subtalar joint work better, like as simple as orthotics or as complex as surgery, may be necessary. Physical therapy to try and strengthen the muscles around there can be helpful. But this is something that needs to be addressed because, of course, sooner or later you're going to have to walk on grass or maybe even sand, and you don't want those joints working outside of their normal range or they will get irreversibly damaged. What are your thoughts on custom foot orthotics? I addressed that earlier. When having orthotics made, which method is better for taking the mold standing or laying down? So you get 10 podiatrists in the room, you're going to get 14 opinions on this. So again, more art than science. I think you need to find out case by case basis. There are CAD/CAM cameras using laser measurements now. So all kinds of, thank you, John, all kinds of ways in which orthotics can be made. We get a lot of good results with just off-the-shelf orthotics, but it's a case-by-case thing. Next question. My son has EDS and is injuring his ankles monthly. It stays really swollen and bruises. Some swelling never goes away. We ice it for at least a week. What do you suggest could help? Well, I think we've talked about that at length. I think he needs proper attention. He probably needs physical therapy. He may need bracing. He may even need surgery. But you must not let this situation go on or his ankles will become unusable all too soon. Let's see. The pain in my right ankle feels identical to how it did prior to surgery for my peroneal tendons. The was shredded so badly that it ended up being excised and anchored to the adjacent one. With my with my recent EDS hypermobility diagnosis, I'm very worried about another tear in my tendon. Given the complications of the surgery in EDS, is it something that is worth seeking attention for? Thank you. Yes. The tendon getting damaged probably wasn't the tendon's fault. It was probably instability of the ankle or subtalar joint. And so addressing that instability with physical medicine, bracing, possibly even surgery is probably necessary. We've also experimented with replacing the perineal. We actually call these fibularis tendons now. My anatomy professors are telling me don't call it perineals anymore. Fibularis kind of makes more sense because perineal is the area under your butt, and your fibularis is near your fibula, so it kind of makes more sense. But if the fibularis tendon is chronically subluxing, it's going to get shredded, whether it's been tied to the fibularis next to it, the fibularis longus, it's still going to happen. So addressing the instability and then possibly replacing the ligament that's supposed to keep it in place behind your ankle can be corrected. Someone said, but you have perineal artery and vein in your leg, foot. Yeah, I know. We're probably going to have to change that terminology too. So replacing that ligament that's supposed to hold those tendons in place, possibly with bone anchors and suture material, may turn out to be the right thing to do. There are other procedures, like sometimes we'll actually cut the fibula bone and rotate it into a better position to keep those tendons from popping out of place. But if they keep popping out of place, they're going to get shredded. I only have about 2 more minutes. My 10-year-old daughter has been wearing over-the-counter orthotic inserts called hot dogs, but as she's gotten older, she's been twisting and spraining her ankles, experiencing foot, knee, and hip and lower back pain on a more frequent basis. The injuries are occurring during recess and one time per week, PE classes, etc. Could it be more helpful if she had custom prescription orthotics? I think that's an excellent place to go next. I think going to the physical therapist for muscle training to try and make up for the ligaments weakness is possibly beneficial. And she might even be getting to the point where surgery is indicated. 10 years old is awfully young, but not out of the question. And again, this situation should not be tolerated because there will be chronic repetitive injuries to the joints that will cause irreversible damage to the joints. That's the thing we want to protect, the joints. So, you know what? I think I'm all the way up to the top of the questions again. I can't believe we talked about 63 questions, but we did.
That was amazing. Good job. You covered them all, and we had I think over 80 to 90 people at the high point of your talk. Some of them petered out towards the end, of course, but thank you for all your time and your patience going through all those very detailed questions. And the attendees were also commenting that they enjoyed seeing your family and their successes and all that personal touch that you put on it. So,
well, I'm glad you enjoyed it. I hope to see as many people as possible up in Baltimore. Remember, I learned from you, so you're doing me a favor by showing up, and hope to meet a lot of you face to face in the next month.
Yeah, thank you for talking at the conference, and we look forward to seeing you there, and we'll point all the limping people your way.
Very good. All right, I'll try to help. All right,
okay,
thank you.
Great. Thank you, and we appreciate everyone's patience through almost 2 hours, and we had a very good presentation tonight. One area that we hadn't covered before, but it's a very important area for those with EDS, and I think we all learned a lot. So thank you for your attendance. Thank you, Doctor. We'll be looking forward to seeing you at the conference.
You're very welcome.
Thank you for attending, everyone.
Good night.